thank you everyone for coming out. I know we've had a great almost 3 days for you now. So it is my great honor to introduce Dr. Phillip Graham for this year's Bennett Lecture in Prevention Science, which is, all of you know, is the event where we get to recognize global leaders in the field of prevention research. So I'm going to share a little bit of background on Phil, and then let you get to it, because I know you've got a lot of great stuff. Great to see some faces who came out to the Child Study Center talk yesterday, which was fantastic, and so looking forward to hearing more. But Dr. Graham is a principal scientist and former director of RTI's Center for Behavioral Health Epidemiology, Implementation and Evaluation Research, where he leads cutting-edge initiatives to address critical public health challenges, including adolescent violence and substance use with over 20 years of experience, more I think. His work focuses on the importance of community and cultural context in the development of effective prevention strategies, which I think we'll get to hear more about today. Dr. Graham's research has informed national efforts to reduce opioid misuse, underage drinking, prescription drug abuse, all through data-driven approaches that ensure real-world impact while thinking deeply about working with communities. And we're honored to have him with us today to share his expertise and insights. So please join me in welcoming this year's Bennett Lecturer, Dr. Phillip Graham.
And Max and I didn't coordinate our outfits, but we go with the black and white thing today in gray. So let me just start by saying thank you. This has been an amazing 2.5 days. I didn't know what to expect other than, I knew there were some really cool folks doing some really cool work. But you have blown my mind. And just in terms of, I told folks earlier, for a brief second, I almost thought being a part of the academy would be cool. I came back to my senses and said, not really, but you had me on edge for a second, and I thought, I could do this academy thing. Again, I want to thank Max and staff at PRC, but also want to thank the administrative staff for making this easy to be here. And I hope that this discussion today will also be a good use of your time. I also hope we'll have time to have a fairly robust conversation about what I'm presenting today. Tell me what makes sense and what doesn't. And I look forward to that feedback. So with that said, we'll get started. So yesterday I showed this slide to folks who are from the CSC, and folks who know me know that I talk about ad nauseum that context matters. And so although you heard my professional bio, that's not who I am. And what I told folks who were yesterday, so I apologize, you have to get a repeat of this, that these icons represent my context, my living, my reason for doing. And so I show them because it's important as we think about doing the work we do, that context is important. And so there's a story embedded in each one of those icons. More than happy to share and talk about that later, but I show it as a way of keeping me grounded, and those are things that make up who I am, not the degrees I have and not the work I've done professionally, but this makes up who I am as a person. So I wanted to share that with you. I love this because it speaks to the challenge of being in the field of prevention. And I think the opioid epidemic has been a classic example of that. We didn't get a chance to develop interventions, test them, and then show them to the world. In the midst of an epidemic, you do any and everything you can to figure out what works. And so this whole notion of building a plane as you are flying is our daily life, right? And so at the end of the day, how do we make that plane stay up as we build the evidence and sharing it with folks? So I use that as a way of thinking about the challenges that we have to do as prevention scientists. If we do our work well, nothing happens, and how do we prove that nothing happens, right? In its simplest terms. So here's what I hope to achieve today, and you can grade me at the end of the day. I want to talk about, making the case for prevention and the power of co-creation. And so we've talked a lot about co-design. I've been reinforced that that is what you all think about too, which is really cool. And so I think there's some natural synergies for discussion there. And then provide some examples around both substance use and misuse and violence prevention efforts that I've been a part of over the last 25 plus years. and then hopefully demonstrate the use of analytic methods to really conduct rigorous research in community-based settings. So how are we going to do that? So the contours of the day, I want to try to use a couple studies and work to illustrate some aspects of that. I've tried to highlight pieces of the work and not go deep. Yesterday, I took 45 minutes to talk about one study. Today, I'm going to try to talk about 3.5 studies in an hour. So hopefully I can make it work without rushing through slides. But first, I want to talk about using advanced methods to address real-world settings. And this is come from work from SAMHSA, specifically CSAP, that I've done over the last probably 15, 20 years, but specifically some national cross-site research that I did. Then we'll talk about a CDC project where we're looking at community level violence and how we are understanding neighborhoods as an N of 1, how we measure outcomes associated with that in the context of during a pandemic in terms of COVID. And then also the role of community voice. And this is a new project I have. I'll focus more on some of the challenges and how we use co-design to kind of refine our design. So I'll probably go through some of the actual study itself, because I really want to talk about just the co-design piece in that last part of today's conversation. So one of the things that I have tried to talk about is the importance of how can we do applied community-based research in a very rigorous way, and how we can use different analytic methods to do that. When earlier today we talked about doing messy work, we've all decided that we're never going to call community-based work messy again, because it only leads to the stigma that is not as rigorous. I will debate folks ad nauseum that that's not the case. It's about how we approach doing the work. So what I want to show is that many of you within CSAP specifically, they developed what's called the Prevention Strategic Framework as a way to help communities plan and hopefully leading to the implementation of evidence-based strategies. Embedded in that, CSAP has 6 strategies. I won't go into the details other than this hasn't changed in 2 decades because of federal legislation. So these are things, a way of kind of categorizing what communities can do. You will see stuff, it's like, I don't understand why this is what it is. And until we can get federal law to change the statutes, this is one way in which they categorize the interventions and programs that are being implemented. So the strategic prevention framework takes communities to a process, and out of that, they select strategies. These strategies have to be placed into these categories for reporting purposes. So I give you that background. So here's what I want to talk about, is that how can we take a process where communities get funded because they're responding to an RFP. There's no randomization whatsoever. And I don't want to upset anyone, but that's the real world. But can we still do rigorous work with those constraints and understanding? So this is the first example. And what we want to assign is what combination of PFS strategies or interventions were more effective. And so what I hope to do in this illustration is the following. One, to talk about how do we understand the combinations of interventions that are implemented by this SAMHSA strategy within communities. And then more importantly, how do we help providers make more informed selections of interventions to address prescription drug misuse and abuse. So here's what we want to do. What types of interventions, both individual and in combination, are pathways to successful achievement of reductions in substance use? And this is the first example of how you might use advanced methods. And so who's familiar with QCA? Okay, cool. So I can make up a whole bunch of stuff today. So it was developed for hospitals as a way to kind of look at figuring out what's working and what's not. As we know, very few communities are doing a single thing. And so at the end of the day, often we're trying to figure out what's happening it's how do you evaluate folks doing a whole bunch of stuff? And the question is, hopefully it's a whole bunch of good stuff. And so we want to figure out, could we use QCA as a way of doing that? And so this language will be different, except for Max and Sarah, but what is QCA? It is an analytic approach that is based on what's called set theory, and it uses formal logic, which is a branch of mathematics and Boolean algebra. I don't understand Boolean algebra, but I don't need to because I have folks who do. but to identify a combination of factors or recipes for achieving an outcome. I think my little person covered up that. I told him not to do that. I apologize. But also QCA uses what are called truth tables to evaluate all combinations of an exploratory condition and identify the most parsimonious and causal pathways. And so this was a way of trying to figure out communities, those 6 things I showed you earlier, folks did different combinations of that. And does it make a difference with respect to outcomes? So here's a different language. So what we want to know is what conditions alone or in combination with other conditions are necessary or sufficient to produce an outcome. And so what we mean by necessary and sufficient is following. A necessary condition or combination must be in place for the outcome to occur, but it does not guarantee that the outcome will occur. A sufficient condition or combination produces the outcome. And so when a sufficient condition is present, the outcome is also present. So that's some of the language that's used with QCA. Now it gets even more interesting in terms of how we create these models. So a condition or outcome set is calibrated by establishing thresholds and decision rules around membership. And we talked about crisp sets and fuzzy sets. And so a crisp set means that you get a designation of 1. That means a case was fully in that condition set, or 0 if it was not fully in that with respect to an outcome. A fuzzy set is when resolution ranges from, we use a 3-point anchor and on a continuous scale to kind of figure out if it's almost in or not. And so these 2 terms will help us create this truth table, which I'll show you as a way of figuring out what combinations of these types of interventions were working versus not. Parameters are fit. So we looked at both consistency, and that's a causal pathway regularly that would produce that outcome of interest. And we're going to look at 30-day alcohol use as to be illustrative here. And then coverage. Solution is empirically relevant and quantifies the variation in the pathways to an outcome or the strength of that relationship. So that's the kind of analytic math behind how QCA and truth tables work. So what we want to do is, again, the conditions were defined as the following: those 6 things that I mentioned: community-based processes, prevention education, alternate drug-free activities, problem identification and referral, environmental strategies, and information dissemination or communication. So those are the 6 types. And so if it was a crisp set, that means that the presence of that strategy type was there. If it got a 0, it was absent. So here's what we did. So SRC stands for subrecipient communities. And so this is an example where these are all 6 of those types, and this shows you the outcomes. And so, and these are the parameters as it respect to the proportion of subrecipients with a combination that reduce past 30-day use. So you'll see this goes, from high association down to low, and these 0s and 1s for these conditions. So here 1 is conditions present, 0 condition is not present, and it's an N of 54, and we looked at reported alcohol use, and then 41 showed decreased use, and this table excludes folks that had an N of 3 where we weren't, the fuzziness was too fuzzy to use in the tables. So here's what we found. And so no conditions or strategy types were individually necessary or sufficient. We found 5 combinations for implementation effectiveness. So for this recipe 1, it looks as following: community-based processes and environmental strategies were associated with reduced alcohol use 100% of the time. We've been talking about Prosper and CTC, and I've been challenging folks on, well, is it the process that's important or the specific strategies within that process, right? So you didn't know this was coming, but this is along those lines, right? And so a combination of those community-based processes, which are akin to CTC and Prosper, with environmental strategies that really look at policy change, were when they were in place, 100% of those communities had reductions in 30-day use. The other recipe had environmental strategies without dissemination were associated with risk 100% of the time. The third recipe had problem identification and referral without prevention education were associated with reductions. The fourth said information dissemination without community-based processes or environmental strategies appeared to be associated. And then the fifth recipe was that environmental strategies without prevention education were associated reductions, about 94 of the folks there. The take-home message is the consistent thing is the role of environmental strategies. And that's really about policy change, population change. And so, and then in combination with the other things and so for the first time, we could begin to say, how can we tell communities how to put together this kind of holistic approach to prevention service delivery? Geographically, this is what it looks like. These were the communities, and here's the overlap. And so, again, these depict, these individual communities as subrecipients. But is this overlapping grouping? And this is just to show you kind of what that looks like in graphic form. So, using this technique that was designed for how hospitals made decisions, we were testing to see if it would work in a community context. And so, what did we learn here? The fact that no individual condition is necessary or sufficient suggests that these CSAP strategies need to be implemented in combination with each other to reduce past 30-day use. In many ways, that's not rocket science, because doing work in community is complex. The interrelated factors that put folks at risk typically cannot be impacted by a single strategy. And so if you were thinking about whole community approaches to addressing some outcome of interest, the combination of multiple strategies that build in a very synergistic way are key to successful outcomes. We also, across that successful pathways and these conditions with these specific types, appeared multiple times, and that was environmental strategies, which highlight they are particularly helpful, but must co-occur with the presence or absence of specific strategies. So again, a common approach is around environmental strategies, but we need to understand in combination or without under what conditions. And then the final kind of take-home message is that with high coverage, successful pathways can provide recipes for success most of the time. The subrecipient community should consider combining these strategies as successful pathways suggest. So this is the first example of how we use an analytic method developed for a different setting and situation to apply it to adding rigor to helping understand what are the combinations that can be used in understanding community success. Right? The second example is around we want to figure out if the impact of these strategies on changes in poisoning center data. Why poisoning center data? As I mentioned before, the way in which communities received funding was based on applying to an application. So we couldn't control who received and who didn't receive funding. We also did not have control of comparison communities. And what I asked my teams is that, can we figure out a way to create these synthetic comparison communities to really begin to look at the impact of these strategies? And so I stretched folks out. They said, I don't think so. And then I stumbled on the National Poisoning Center data and asked a question. 60 million plus exposure cases dating back to 1983, all 50 states, including DC and several territories. These poisoning cases are tracked based on separate drug cases, including antidepressants, ethanol, sedatives, stimulants, and opioids. And so for our evaluation, the cases were restricted to individuals between the ages of 12 and 25 for all domains except ethanol because it was a little unstable. But then we had data from multiple years for this particular intervention. So, and what I didn't have here, that data was down to the zip code level, which means we could actually create synthetic comparison communities based on who was receiving PFS using data that was available multiple years prior to when we started this work and as long as this work was going on. So once we identify that data source, we work with NPSD to see if we get access to it. And at the time, they weren't sharing it nationally. We convinced them that we should. We got SAMHSA to pay for it. And since then, they've raised the price because they realized they had created a new market that they hadn't tapped in before. Kind of utility of this data. And this is people calling in for all suspected poisonings, and this data being recorded. So here's what we did. So the data for the National Reporting Data System are included in these individual case forms, but we need to do a couple things. One, we needed to aggregate up to the community level, and then we needed to convert poisoning data into rates. And so we did that looking at per 10,000 cases, young youth and young adults. Ultimately, we wanted to achieve the following. So how do we compare changes in poisoning rates in these PFS communities compared to rates in non-PFS communities? And because communities were not randomly assigned, we had to deal with additional potential confounding variables and figure out how we address that. And we did that by using propensity score matching. So my team then created a set of variables and factors, then use propensity score modeling to really balance out any pre-existing differences. So again, no randomization, but again, using these other analytic methods to kind of, can we create as much similarity as possible, and then to do this analysis. So here's what we found. And again, as I said, I'm showing highlights because I have lots of examples to share with you all today. And so more than happy to answer any additional questions. When compared to non-PFS communities, PFS communities had meaningfully smaller increases in overall calls for poisoning related to alcohol and prescription drugs. We talked earlier about if trends are going up and you don't have comparison groups, folks say, oh, that intervention strategy is not working, right? And so having this additional data allowed us to demonstrate the following. Pretty much a flat line and looking over 4 years in terms of what those PFS communities, in terms of their reporting of poisoning versus here's our comparison community. We wouldn't have known that if we were unable to create that synthetic comparison. And so again, the propensity score matching processes were they were iterative and making sure we're using the right data to create these equivalencies, and then using it in this context. And so another example of how we're using analytic methods to bring rigor to community-based settings where CSAP had never done or hadn't thought about, even in the natural cross-site work, how to have comparison communities. The reason we think we won the work was because I had worked at the state level and knew all the problems of what previous national cross-site evaluation was doing, and the lack of rigor and the lack of utility in terms of how you look at data. So it's almost that understanding of the challenges and failures of previous attempts to do this work and bringing that rigor in, because we're fortunate to have some really strong Penn State trained methodologists at RTI. And so so in summary, a couple things. We demonstrated that reductions in risk over time for poisoning at the community level for PFS communities as compared to non-community did exist. And so we also accomplished this despite the following. With a design in which PFS communities were not randomly selected, and with greater community risk at baseline for some versus the other, and with archival data sourcing. So again, that was really finding the right data source that aligned with the outcome of interest, and then using those methods to combine the two. So that's the first example. I want to shift gears and now talk about my work I place in 2 buckets, all prevention oriented, but some substance use, misuse, and abuse, and violence prevention. So what I want to talk about now is a project that I have in Milwaukee, really looking at violence prevention at a community level. So this particular project is called Adverse Community Experiences and Resilience, ACER, for preventing violence and ACEs in local communities in the city of Milwaukee. And so had the pleasure of partnering with CDC as a funder, but also Prevention Institute, who does amazing community level work and really understanding the issues of equity and how we think about doing work in community. And then also with the Milwaukee Office of Violence Prevention. As I said before, I will overuse the word context. And so again, I would be remiss if I didn't talk about this. And so really thinking about how violence has devastated communities, but also recognizing not just at the inner city and that violence is everywhere, and having folks understand its full breadth. Exposure to adverse experiences can have lasting effects on those who are exposed. But one of the things we're also talked about is those who live in communities where there's a history of inequities and structural barriers are even more affected by these experiences. And then, as you all know, there's renewed interest and issues around gun violence, community violence interventions. And so there's been this kind of national swell around how can we do and understand this work better. I show this as one of my favorite ACEs examples because of the following. We normally stay here when we're thinking about issues of ACEs, but these things below, which adverse community environments, are just as important, and understanding that they do not operate in isolation. And so this is another example of it's not either or, this is the and, because this is the reality in which people live. So when you have interventions that focus on the individual, but you don't realize that the individual goes back to your community environment, and you don't do anything to that environment, our expectations with respect to outcomes may be misleading. And so I show this to really kind of talk about this in context as kind of peer ACEs and showing some of these concepts. Josh, we talked about social capital as an example, and that's about, how networks lead to access to resources, and then about how people relate to each other within community as an example. So anyway, I wanted to share that with you. The other piece I want to share is, again, our partner was Prevention Institute, and they created this framework around what they called adverse community experiences, not at the individual level, but at the community level. And so the work that they were doing was the work I was interested in better understanding and how we might partner in this project I'll talk about in a minute. So the origin of ACEs is following. It's really based on this notion of community trauma and its impact, and a couple of key things. They talk about trauma manifests at the community level, not only at the aggregate level of individuals in a neighborhood who have experienced trauma, but really the cumulative effect that goes beyond what one might experience personally. Community trauma is the impact of chronic adversity kind of across that community, and how that changes how people think about their futures, how they interact with others. And then trauma is a barrier to finding effective solutions to promote health, safety, and well-being. And this is one of the things we talk about: engagement, right? Depending on the level of violence in the community, and you're trying to get folks to participate, that fear in and of itself can hinder or result in folks not engaging because of that fear, right? And so as we think about our strategies about how do we bring community in, understanding how community trauma shows up with respect to people's engagement is a key aspect of understanding that. And the last piece, the manifestations or symptoms of community trauma are present in the social, cultural, physical built environment and economic environment. So here's what Prevention Institute talked about. These are the symptoms, but in terms of solutions, it's the issue of equitable opportunities, thinking about people, and that's a social cultural environment, and then place, the built environment. And that can show up in a couple of ways. When we talk about equitable opportunity, that's intergenerational poverty, long-term unemployment, jobs, limited unemployment, disinvestment. Place is talking about, in Milwaukee in particular, the long-term effects of redlining was something that you hear about, but you see it in practice, and how that changes the built environment, and how that intergenerationally casts down in ways that you're like, well, that happened in 1930. It is still having impacts in 2024. And really understanding those dynamics are important to really understanding community context. With respect to people, kind of this disconnected social relationships, the social networks. We've been talking a lot about social networks in some of our meetings with some of your colleagues over the last 2 days. The kind of elevation and destructive or dislocating social norms, and then a low sense of collective political and social efficacy about people's willingness to engage. And so the Prevention Institute talks about this is some of the negative impacts of community trauma, and these are some of the things you need to contend with if you're going to address it. But here's the cool piece they also talk about, and it gets back to those two ACEs. You can't just focus on individuals in those communities. You have to focus on the systems that serve them. And so the other part of their model is around what are the community strategies that need to be thought about, and then what are the individual approaches. And again, it's not either or, it has to be and if we're really going to bring about meaningful community change. So I knew about the work that was going on in Milwaukee. And I was fascinated by the work that Prevention Institute does. Is they take these models and they come into communities and they help them create a plan. And so what they created was the Blueprint for Peace. This is a 12-month process in which they involve every sector in the community, including gathering data from like 1,500 youth, police and law enforcement, public health. Everyone contributed. What do we need to do to address violence in our communities? And out of that, they came up with these goals. Now, these goals are not strategies. Within these goals, they needed to also identify strategies. But these were the 6 things they came up with. And so this was a way of kind of guiding the work of the Office of Violence Prevention. So I was interested in understanding what that looked like in practice, but I was also interested in what is the role of community organizing and really elevating this work. And I'll talk about the other thing, other pieces we asked Prevention Institute to think about. So we wrote a proposal, a beautiful proposal to CDC. Only one funded in that funding round. So the beautiful part comes from them, not me. So, and I think part of it is I have been figuring out how to think about the role of implementation science and evaluation work for the last couple of years. And so I think we were a little ahead of the curve. And so here's what we wanted to do. We first wanted to retrospectively measure ACE's implementation, effectiveness on reducing child abuse, neglect, and youth violence in Milwaukee using idiographic clinical approach, or ICT. And that's really comes out of precision medicine N of 1. So those of you know Ty Ridenauer, Ty had been doing N of 1 studies. And so this is, again, me figuring out how can we use methods in different ways. And we think about neighborhoods and neighborhoods specifically as a single unit, right? And so could we use this kind of N of 1 concepts to think about, because in the early days, CDC said, we want you to do neighborhood level work. And you'd submit a proposal, and then they forgot to tell the reviewers who would come back, your sample size is not large enough. Most frustrating thing ever. So a wonderful concept, but if you forget to tell the reviewers that we're looking at this differently, then you didn't get funded, right? And so this is an example to think about that. Then prospectively, we wanted to test the comparative effectiveness of ACER framework, which is a blueprint for peace, plus community organizing in 10 communities that Milwaukee identifies as priorities, where had the highest levels of violence. And then this is the other cool piece, using a hybrid type 1 effectiveness implementation design to explore the barriers and facilitators of implementing community organizing within the ACER framework in a large metropolitan area, i.e. Bend, Milwaukee. So those were our aims. So here are results, and so I want to caveat all of this. So this thing called COVID is going to show up and wreak havoc, and we had to figure out analytically and theoretically and conceptually what did that mean as we were looking at what's working, what's not working. So here's our design, and so again, they had been doing this work kind of started in 2016. So we call that the pre-phase and understanding what that looked like. Then from 2016 to 2020 is when they were just doing blueprint. We weren't involved, but they were collecting enough data that we could retrospectively kind of organize what was happening and really look at, and particularly in terms of outcome data, what was going on. And then you'll see here is our study, right? And so we had, there were 10 communities, and what we randomly assigned 6 of them to ACER only, and 4 of them were supposed to get ACER, which is his blueprint, these activities, plus this, this training and technical assistance around community organizing. So just to show you, here are the communities. And so these 6 got treatment as usual, and these 4 were supposed to get the community organizing that was developed by Prevention Institute. here's what that training looks like. So we wanted to have a dynamic a set of tools and having folks think about community organizing. So this is what they came up with. So this is kind of what they call a continuum of community building and organizing. And it had these 4 major components. There was a civic engagement component. There was a community engagement component. There was a community organizing component, and there was a movement building. And I can go over the definitions, but these were some of the operational definitions. Civic engagement, residents act to influence and change public sector leadership policies and practices. When we talk about community engagement, it's that residents become involved in opportunity to influence the safety and well-being of their families and communities. Organizing is about building collective power to influence change, and movement building was aligning those interests and building capacity for ongoing engagement, organizing, and power building. And so that was the major content of that training that we asked them to do. They then divided it into 5 modules. So the first module was systematic and historical trauma. Having folks understand what they meant by community trauma was step 1. The second module was understanding the social determinants of health. And they had another project called Thrive in terms of how you improve based on that understanding. Then they had to addressing and preventing community trauma and healing, what that might look like in practice in terms of strategies, and then building resident leadership and voice. That was how you empower individuals to really speak on behalf of their neighborhoods and communities. And the last was resident leadership and action. This is about how we get to doing work. Why was this important? So one of the things that was important in terms of our retrospective was the following. Milwaukee had done an incredible job of involving community in the development of the plan. When the plan was developed and finished, the Office of Violence Prevention implemented the plan. What did that mean? Residents were not involved directly in the development of these strategies and activities. They could become co-partners, but they were not leading. And so we learned this in doing some of our early retrospective analysis, much to the surprise of everyone. And so that was really the emphasis about how can community organizing really connect it to that folks know what the blueprint is, and how can they be active participants in its execution. And so our hopes were that by participating in this community organizing training, a training model, that we would see more of that over time. So here are our research questions. So what was the effect of the Blueprint for Peace in Milwaukee on firearm violence, child abuse, neglect, and youth violence? What is the effect of community organizing as an additional component to that? And then on the implementation science side, how do outer and inner settings factors shape barriers and facilitators, stakeholders in the implementation of these strategies? And then how can strategies be identified for stakeholders to address community trauma? And then last, what strategies facilitate the process of implementing the intervention and prevention of violence? Now, mind you, I told you there's a little thing called COVID that came up, right? And so we'll talk about its impact. Analytically, we wanted to quantitatively aggregate data by month and neighborhood. So one of the things, I don't think I have it here, is we created what I call an events tracker. And an events tracker is based on this notion of community touch. What we want to say, any and everything that was done in neighborhood, big or small, was considered an activity. It was a touch. And that could be handing out firearm locks, having a community fair. We didn't care. We wanted to document everything that was done in each one of these 10 communities and to quantify it if something occurred. So we spent time working with staff, reviewing calendars, conversations about what did you do? And so we mapped that out monthly for all 10 communities. And that was a way of looking at issues of dosage. We're also doing some additional work in terms of kind of gauging the kinds of activities that get more value. For example, as a part of this intervention, there's a group that calls 4-1 for Life, and they are community violence interveners. Their work is real time in terms of addressing issues of violence and retaliation. So when that happens in one of those communities, it gets a little more value than if I passed out a community awareness flyer in that same community. So we're still working on how to organize that and really look at long-term dosage, but we documented each and every one of those activities in those 10 priority communities. Then we had to estimate the effects of intervention at the neighborhood level, and we did it by testing multi-level models, and I'll talk about how we also tried to account for COVID-19. The reason I say account for COVID-19, one of the things we figured, we anchored it in time. So the dates we used were March 2020 to April 2021 to see if we need to understand did something different happen in that period. And one of the things we found, for example, we had these violence interrupters whose job was to stop retaliation, but during COVID, they were doing everything from dropping off diapers to bringing supplies to folks. So they were still doing work, but they weren't always doing the work that they were hired to do. And it was a kind of community response. And so this is when I was engaging folks to say that we weren't saying you're not doing work, but we understand that work looked different in that period of time. And should we account for it? And how should we account for it analytically? So here's what we did. So first we started by using a couple multi-level negative binomial regressions, and where we control for total population, percent Black population, median income, percent of families in poverty, unemployment, and folks under 18. And so one of the things that we found out initially was after the blueprint was implemented, communities had a 29% reduction in homicide rates, 33% reduction in firearm homicide rates, 29 in terms of non-fatal shooting, and 26% reduction in the rate of total incidents. So that was just kind of looking at outcomes as it related to pre-blueprint, post-blueprint. But we also want to think about the community organizing piece, and this is where COVID wreaked its most havoc. So this is supposed to be in person, in community with residents. When the COVID happened, we had to then change to a model of we're going to do community organizing via Zoom. Major disaster. It was difficult to get people there. It was difficult to people engaged, and so the communities that received the community organizing training did not experience anything statistically different in terms of violent outcome, and we never expected to. Right? We knew early on that there had to be in-person engagement to really involve folks, and because of lots of implementation issues, only 2 of those 4 communities received that training. And so what we did was, and it's not here today, but we're writing it up, we really focused on implementation learnings based on that we knew going in that COVID was not going to allow us to test this in the way it was designed, but we could understand how the barriers and challenges to trying to do community organizing via virtual spaces, and what were the pros and cons of that. And so the team is writing those lessons learned up, but just looking at the impact of the blueprint, we still did see changes. Also, one of the things in terms of COVID-19. So COVID-19 period, I think, aligned what we use school closings as that anchor. So we didn't just randomly select the time. We tried to anchor that empirically. Like everything shut down in March of 2020, began to open up in March 2021. So even in terms of looking at what things were happening, we're able to kind of look at that time period, account for it analytically, and then again, same process, and here's what we found. Compared to all other periods during that COVID lockdown, 2020 to 2021, there was a 30% increase in homicide rates, a 43% increase in firearm homicide rates, 38 in terms of non-fatal, and 30% increase in terms of rates of total incident. If we didn't take the time to disaggregate and kind of understand the impact of a hopefully once in a lifetime natural occurrence, this would have been hidden in our data. And so that spike was seen everywhere across the country, right? During COVID, rates of violence spiked. We don't all understand why, other than, but it was a phenomenon that many cities and communities saw. We tried to compensate for that understanding in our analytic model to really understand, but how did the blueprint work under the most ideal conditions? So the other thing we did was we were able to work with law enforcement and get police call data for multiple years for all of these communities. And so then we create these categories based on that call data. And you'll see here, here are the categories we created: shot disturbance, assault, suspicious weapon activity, call for police where folks said, please come, family domestic violence, threats, domestic and child abuse, juvenile disturbance, armed robbery, reckless driving, and sexual assault. Reckless driving, because evidently in Milwaukee, there's these issues with street driving that puts people at risk for injury. So they were interested in that, so we included. So we categorize all that police call data in the following to use it as a way of understanding community response and reporting as it relates to these types of crime and violent behavior. So here's what we found. So we looked at the difference in the number of neighborhood calls within these communities, and we had, in addition to our 10 priority communities, we also created another 10 comparison communities. And so you'll see here as an example, I'll use, let's see, which one should I use? I'll use shot disturbance, right? So you'll see here on average per month, 7.2 calls for service around shot disturbances. And we looked at the change in the number of monthly calls for Blueprint after Blueprints was implemented. And so you see instead of 7.2 to only 3.7 per month. One of the other interesting things we saw is, for example, here, calls for police. Prior to Blueprint's been implemented, 6.2 calls and then 2.2. And so here, this is a way of, again, understanding using existing data as a way of seeing how these interventions strategies may have impacted the work. And so again, this was, and I use this example here so you can see more clearly. It says, so again, across the study period was 2015 to 2023. Priority neighborhoods had 7.2 more calls per month on disturbances compared to the controlled neighborhoods. However, there were 3.7 fewer monthly neighborhood calls for service for these shot disturbances after the Blueprint. And so again, we combine those 10 priority neighborhoods who should have been getting Blueprint strategies against a set of comparable comparison communities within the city of Milwaukee. So here are our challenges and lessons learned. So, and how am I doing on time? All right, cool. Community level effectiveness analysis is complex, can take time, and may necessitate adding additional processes and partners, but it's possible and it's meaningful. And I say that because it's not easy to do what we did, but I think it's important to make sure we're looking at neighborhood changes in a way that makes the most sense. Community partnerships are key to study recruitment, and in delivering the community organizing via Zoom may not be an effective method to engage local residents. And so controlling for COVID and are compensated for its impact on the intervention activities is needed to really disentangle the effectiveness of this Blueprint approach. And so again, using both analytic methods, implementation science concepts, and really thinking in practical terms about what's happening on the ground, using our analytic models to really mimic that in a way that we really can look at a very complex problem and still be done in a very rigorous data-driven way. So that's my second example. And so I'm going to rush through my third example because I want to have time for Q&A. This is my current project. And so I have a project with CDC that looks at the intersection between ACEs and opioids and thinking about what kind of strategies can really help reduce based on that intersection. And so one of the things we wanted to figure out is what that might look like in practice. And so what we did was we worked with the state of New Jersey. And so this title is way too long, and I can't believe I came up with a title like that because you can't put it on the slide. But here it is: evaluating ACEs targeting advocate models of substance use prevention program in 36 New Jersey communities experiencing disproportionate burden of substance use in ACEs. I apologize for that foolishness. I don't know who thought that was a good idea, but just quickly, this notion, you all know what ACEs are. And so part of it is understanding its relationship in terms of ACEs and negative outcomes. And so what we wanted to focus on was really how common of ACEs in these communities, who most commonly experiences ACEs, and what would we need to do in this intersection between ACEs and SUD. So early exposure to ACEs, of course, can have results in kind of cascading effects over time on both substance use and adverse outcomes with individuals who are exposed to them. And unlike many other adverse outcomes, ACEs can play a more immediate role in substance use initiation among youth. And then the relationship between ACEs and substance use is observed here in the kind of dose response fashion. The more ACEs you have, the higher your risk. And so we want to figure out how might we intervene. And here I want to talk about it. So what we wanted to really was to understand what, when left unaddressed, kind of this intergenerational relationship between ACEs and SUD, how it affects the larger community, not just the families and individuals, but the larger community. And so, and what are the community level factors that play a substantial role in really increasing or mitigating ACEs in families? And so out of that, we began to think about what are the interventions that make the most sense. And what we came up with the following. We thought about in New Jersey, they do a lot of work around using strengthened families. And so they did it well, had done it for many years. And so again, we wanted to figure out what we might add to that to see if we could have in heightened or stronger results when combining it with another strategy. Let's see. So here's what we did. So in New Jersey, ACEs prevalence is often higher than the national average. In 2020, about 82,000 folks had been admitted primary doses with SUD. And then because New Jersey was fairly diverse in its landscape, both rural, urban, and suburban communities, we thought we could really test out some intervention models. So this is what we did. So we looked at SPF and a weekly family, which is a weekly family skills focused training, and then wanted to add to that family advocacy, based on the following assumption that, people often get referred to services and treatment. We have no idea if they ever actually attend those. And so the question was, if we add a family advocate model to SFP, would we have better results? Based on this conventional model in terms of what we expected, the following, we thought about this in the ecological perspective and hypothesized the following mechanism of change. Families would receive the increased number of tailored service referrals if they had a family advocate. Service referrals and repeated contacts between systems and agencies would also facilitate system linkages. And so here we thought if systems and services begin to talk to each other, those linkages would build longer relationships and have systems level change with respect to service delivery for these families. And then we also thought community level process change would contribute to reductions and long-term effects of both exposure to ACEs and SUD among both adults and children who participated in the study. So again, we want to take advantage of implementation science. So we came up with a hybrid type 1 design that was ideally suited for this kind of work. And then this study consists of 3 components. First, we had a cluster randomized RCT. And I know I've been railing against RCT since I landed at Penn State. However, I still think they have value, but we wanted to see what that looked like. And so we use that to test the effectiveness of these interventions among these 36 communities. 18 randomly assigned to SFP as normal, another 18 randomly assigned to SFP plus FA. And then we include a process evaluation to really understand issues of implementation, both barriers and facilitators. And then we also had a cost. I don't think I told you this, did I? It has a cost evaluation. So and I'd love to talk to you and Damon about that as well, but was estimate the cost required to implement the interventions and assess the kind of overall cost effectiveness. All that's good, but that's not what I want to talk about. Here's what I want to talk about today. There's this importance of co-design and understanding the importance of it and finalizing evaluation design. This is a 5-year study, and we actually took a whole year to refine the study before implementing. Had we not had that year to do that, is my contention that we would have failed miserably. And so I want to talk about a couple of examples. The first was around what to do. There were 3 types of SFP, SFP 7, SFP 11, and 14. Mind you, this is coming out of COVID. And so we wanted to use the one that had the most evidence. We wanted to do SFP 14. It's 14 sessions and I forget the age range. We shared that with our partners and communities. It's like, no one's going to come. We're just coming out of COVID. People's levels of interaction have changed. And if you try to get our providers to provide it, not going to work. Can we do SFP 7? We said, sure, but then we looked, there's not a lot of evidence on the effectiveness of SFP 7. Some of it's done virtually. And we said, We can't do that. Let's compromise. Our compromise based on looking at data and sharing that back and forth was SFP 11. Had we proceeded with 14, we would have got no families. We proceeded with 7. I couldn't really talk about, type 1 hybrid design is based on the fact that using evidence-based strategies and of course, looking at barriers and facilitators of implementation. So that was the first thing we did. The next was community selection. And so we used 3 types of data to really identify communities that were high levels of ACEs, child abuse and neglect, and overdoses. And then that's how we rank ordered them to be able to select them. But we show that to neighborhoods, and some folks were upset because they said that did not represent who they were. And what we realized was that we were using data that they didn't have access to. And so in their mind, they were higher or lower than what we were showing. So we had to spend time to convince folks that, one, this data was credible. What we were showing them was valid before we finalized our kind of creating clusters on which to pull communities out of. The third thing was around partnership and agency recruitment. The issue of capacity, because they were already doing strengthening families in many communities, we didn't think about whether or not folks would do this or not. We figured they would say yes because we're paying them, but there were capacity issues where folks said, we just can't do it. And then there were workforce issues. And folks said that it's going to cost you a lot more than you thought. And so again, we had to negotiate and understand all of those dynamics to really show folks, well, here are a couple of different ways in which we can partner. We said some communities you randomly selected now because we did all 36 communities at one time. And we then decided we were doing them 12 each year, try to do 12 communities, 6 control, 6 treatment. But we didn't have to do it like that. And so we said, that's fine. We'll move you out. You can do more recruitment, build your capacity, and we still have the same communities, but they just wouldn't have been in cohort 1 or cohort 2. And then the last piece was probably the most significant piece is that this whole notion of gathering data on ACEs. And we realized that we're going to ask families about how many times you beat your kid and how many times you were a terrible parent. Nobody was going to come to SFP because ACEs screener is not a part of SFP. And so we had that, epiphany like, hey, that makes sense. Why would I answer this and then come to this program given the questions you're asking me? So instead of a traditional ACEs screeners, we work with some folks who've been doing some important work in Colorado around ACEs. And so we came up with a social needs screener. A social needs screener really focused on the social determinants of health and understanding what families' needs might be. And that's the information we gave to our family advocate. Again, it took us a year to work through all of this before we started implementation. But that year later when we started, we got all communities to sign on. We were able to recruit families for every site, and we're able to implement and gather all of this data. And this would not have happened if we didn't spend the time to talk to the different partners and really tweak that design based on our understanding of what was on the ground or the context of New Jersey. And so I want to overemphasize, one, telling funders you need time to be able to do this. I mean, we all write beautiful proposals, and they are more than ideal. And then the reality of how we do it once funded, you have to hit the ground running. Many of you know that, right? And hitting that ground running without having the opportunity to do this leads to all kind of unintended consequences. And so we were fortunate to be able to do this. And I've been working with colleagues and the importance of, I consider this community voice. And so if we hadn't listened to each one of those individual pieces, we'd be in a different place. And we still have to do that as we move from the first cohort. We're starting year 3 in cohort 2 of understanding what are community dynamics, what kind of adjustments we need to make without violating any of the rigor of the work. So I am in closing at 1 minute. The promise of prevention is where we started, right? A couple of take-home things. It does not matter if we're talking about substance use or violence. I think these couple things are what I want you to take home. Upstream prevention will require efforts that re-examine how we think about age, place, and context. Upstream prevention will require us using data and theory-informed methods differently to improve the implementation of preventive interventions. And upstream prevention will require comprehensive systems integration thinking to scale and sustain prevention-oriented outcomes. And this is my only soapbox moment. We will never truly bend these curves of despair until we fully implement the power of co-created prevention through the use of upstream evidence strategies that are culturally relevant and understand the context in which we're working. So it is 5 o'clock. I am on time. And so I want to again thank you all for allowing me to share. And so hopefully we now can engage in a conversation around any aspect of what I've shared. And thank you for providing me this opportunity.
We do now have time for questions, so I can run mic around for people who would like to start.
Thank you. Dr. Grant, thank you. In the Milwaukee study and the New Jersey study specifically, you talked and referenced the erosion of community contact related to COVID and the time it takes for you and your research team to essentially rebuild those connections. So I'm just wondering if you can speak to the researcher as de facto community organizer post-COVID versus being an objective observer of events in a community. And is that a false dichotomy?
It's my personal belief that one does not have to be distant to be objective. And an example I use in the old way of evaluation, it was the evaluator would come in at the end, gather the data, do an assessment, this thing worked or didn't. He or she didn't understand context. And so for me, the way I think about evaluation, and I think hopefully this answers your question, is that I first want to make sure I know what was done before I talk about what worked and didn't work, right? If you're not engaging and having a feedback loop where we can say, hey, you said you were doing X, as we are gathering information, looks like you're doing Y. Was that intended or not? I haven't changed what you're supposed to be doing, what I'm supposed to be evaluating, but what I've said is that I want to see if what you said you were going to do really works, right? And having that feedback loop for me is not in any way tainting the rigor or the validity of the study. So for me, it is this notion, and this has particularly come up in the CVI space, in that, you know, what does inclusive research look like, right? And how can we do it in a way that is not contaminating what we're doing, but also recognizing we have to understand what's being done and how can our methods and sharing real-time data for course correction be used so that at the end of the day, I can say it was SFP and FA, not, you know, diddly squat and nothing. And so that's how I think about it, and think we can demonstrate that you still can do that work well, and still be done in a very objective way.
So I'm going to take a guess. I didn't see New Jersey or Milwaukee icons on your icon page. So you as an evaluator or researcher ended up doing really great community work research in those communities. Can you share with us a little bit about how you and your team created relationships to make that work successful?
Oh, absolutely. So it's about partnerships by extension. So there were other colleagues at RTI who've been doing work with the folks in New Jersey, specifically the New Jersey Prevention Network, and then RWJ Barnes. And so this is where we talked about this before. This is where I had to leverage my colleagues' relationships in saying that I know you guys have been working with folks in New Jersey. I know they're doing this. Can we meet with them to share this idea and concept? And we met with them, shared the idea and concept and say, would you be willing to partner with us? So they were a part of the proposal writing process, giving feedback and content and understanding New Jersey. So that's how that one came. So I really leveraged relationships with my colleagues. Milwaukee, I leveraged relationship prevention. I've been working with Prevention Institute for years, and I value their work. They are incredible partners. And so again, they were working in Milwaukee. And so I, again, reached out to them and said, I want to do this work in Milwaukee because I know what you've been doing on Pacer. Can you bring a group of folks together so I can share? So part of that was showing up in a very authentic way and saying, here's what we want to do, here's why we want to do it. And so again, because I had developed a strong and credible relationship with the Prevention Institute, they were able to vouch on my behalf. And so from there, all the other pieces began to happen. And so we developed a great relationship with OVP, and then by extension, the community in terms of engagement, but really it was previous relationship with other organizations where they would not just say, hey, talk to these folks, they would speak on my behalf around this would be a good person and organization. You know, we struggle with the RTI. Is it RTI or is it Phillip Graham and RTI? And what I say is it's Phillip Graham who gets to use all the resources at RTI to do good work, but it still starts with the individual researcher. And so do I get a benefit or from being attached to, you know, this large, incredible organization? Absolutely. But it's those two things in partnership. And so I start each one of saying, here are my partners. You know, in the contract research world, we use this thing about subcontractors. I never use that term because partnership and relationship building is important to me. So anyone who's working with me, I'm calling you a partner. I'll tell you a funny story. I've had one project with my wife, a social capital project. We've never worked together. And so I called her and I said, you know, you're a subcontractor. And she said, wait, that's the first and last time you ever used that term. You know, we are partners in every way. And I was being facetious, right? But the point is that it lands differently if folks feel like that this is, you are here and I am here, but you really need me to be where you want to go. And so words matter. And so for me, you will always see me acknowledge my partners and call them partners in this work. I think there was a question behind Sarah.
Yes, thank you for an amazing talk. I want to ask, seems to me that the topic you keep talking about seems to be a little bit of flexibility in methods, flexibility in what you encounter. And then at the end, you mentioned this idea of compromising between these three options. And so I wanted to ask you, like, how do you manage to strike a balance when you're facing situations where you may want to have X project implemented this way versus say what's possible or what you end up coming from conversations with the partners that you're engaging with?
I think at the end of the day, for me, is that we don't violate any methodological assumptions and conditions. What we do, though, is make sure we fully understand the context in which we're working. So, for example, in New Jersey, we had within each category, we had like 5 or 6 neighborhoods that would be eligible to participate. And so we might have a circumstance where one of them was like, no. We didn't just randomly pick someone who said yes. We still had to make sure we kind of like randomization was replacement, right? We just moved down the list. So we stayed in that same category. So we didn't change the rigor. We didn't pick someone for convenience, but we made sure we had more than a single choice because it would be naive to think everyone's going to say yes, right? So we made sure we divided the data in a way that there were multiple choices and options within an empirically defined category. So as an example, the flexibility piece is, it is a reality of doing work in community. And again, it's based on understanding how wide is my confidence interval, what I can do, and staying within. So I would say at the end of the day, we always stay within the guardrails. We might bounce a little bit, but we stay within that. And that's really how I think about flexibility without going out the outside and doing something of convenience. Then someone's going to pick it apart and say, well, that's not being rigorous and objective. I don't think anything I've shown you today, and if I conveyed that, I apologize. None of that is subjective. It is all objective with those caveats.
Thank you. Other questions? Joshi?
So this isn't about any of the studies, but your first or second slide was all of the icons, where you're from, what represents you. And your last slide is the power of prevention. So that first slide, in my opinion, is kind of reflecting your positionality. And in culturally responsive and equitable evaluation, we talk a lot about the positionality of the evaluator, of the researcher. And so I'm wondering if you have any thoughts for us as prevention science, how we might think more about positionality and our positionality and ways that shows up in our research and how we interpret our findings and understand the impact of our science. So,
One way is that we should be one expert of a collective of experts. And those other experts are those that we are partnering with to do the work. And you should never have complete isolation in how you interpret what you have and how you build better relationships with the people that you're working with. So like in Milwaukee, every time we had data that we could do preliminary data, we make the runs, we ask, how does that resonate? Sometimes they wouldn't understand all the methods behind it, but what does it mean? And for example, when we said, hey, we need these data disaggregated so that we can really talk about what you're doing. Before it's like, we can't disaggregate. But when we said, this will help us do a better job of talking about what you're doing, all of a sudden, somebody got on the phone and called someone else, and we got disaggregated data. That was because of relationship and partnership and understanding that they are valuable and needed players in doing this work right. And so for me, the issue is about humility, right? And that we call ourselves experts, but be careful about how that shows up. And that, you know, I talked earlier, I gave a keynote last week around different types of evidence and the valuable role of contextual and experimental evidence in partnership with best research available. I think when we understand how those two pieces are used and integrated into our best research available, I think we show up better because then we value the experiences of others and those that lived experience. And so we can combine those three types of evidence. I think we do better work in terms of community level research.
Other questions? Well, people are thinking, I have one. So one, thank you for the incredible talk. Just tremendous from the work on co-design to thinking about communities to the really striking work in terms of gun violence. Just really incredible. So many of you know that, but for those of you who don't, Phil is president-elect of the Society for Prevention Research, so our incoming president. And I wonder, as we reflect on the work that you presented tonight, the work that you've shared with us over the last 2 days, and you think about as you step into this role for the Society of Prevention Research, which is one of our main professional organizations here at the PRC, what does this look like for the larger prevention community, right? That this type of work and what I would say is the momentum, right, behind this work and recognition that's important of which you are a leader.
So part of what I hope to be able to do is to have a conversation and be able to demonstrate that examples of what I provided today are not watered down ways in which to do rigorous research, right? Because I think that's where people start, and that this is some way less than or in violation of, therefore it is less objective. And so part of what I'm going to be asking folks for is to help me do a better job of making the case for why this is important and how it can be done in a way that removes some of the stigma that's attached, right? And so that's one of the things I want to do. The other piece is really around pushing the importance mixed methods in doing social community level interventions as a necessary and absolute approach to doing the work. So if you have an RCT and you don't have those other contextual pieces as a key component of it, then I want to challenge the why. And so those are some, I'm working on the delivery of that, understanding what the challenges are. But also, and then the last piece, and then the toughest piece is this notion of what do we do with other kinds of evidence, right? And where is its place on the continuum of thinking about how we incorporate it into the work we're doing and really moving our science further so that we can, again, explain more of the variance, have bigger effect sizes, and understand that contextual information that we get from those lived experiences. How do we incorporate it into our theory development, right? And not adaptation. I wrote a paper around what would it look like if folks were involved at T0 in the development of interventions, right? And theory development. That's not easy. However, I think, and Mark, you talked about talking to Dalai Lama. I would say, as an example, the mindfulness stuff that you came up with, the person who knew the most about it helped you in your theory development because they were there. You didn't read about what the Dalai Lama had done. You didn't bring them in afterwards. It happened a very iterative, in-person, in-place way. That's how we need to think about developing interventions. Interventions can't be static. They need to be understanding the current time frame and contemporary challenges we face. How we update them, that's another funding challenge. But nothing ever works forever, right? And so how we think about social interventions in that way, and the innovations that we bring. So those are some of the things that I've been thinking about that I'd like to be a part of my SPR platform. I'm going to need you and others to help me think through how to talk and articulate in a way that folks don't, there'll be a little resistance that I don't care about, but I also need to make sure I'm well armed, and because then they want to convince folks in a very empirical, defensible way, but why this is important. So that's kind of my early thinking. I had 6-7 months to kind of fine tune it, but those are some of the things that I've been thinking about.
It's good to get the sneak preview. So, Sarah.
Dr. Graham, I want to thank you for all the 2.5 days. And so a couple of disparate ideas that I'd like to try to tie together, and it'll either be a question or just a seed for future thought, is the idea of co-creation, the idea of sharing lived experiences, and the idea of reducing stigma. And so reducing stigma around, So how can we co-create content that tells the story of the impact that the co-creation process has had on communities and how that's been successful? Does that make sense?
Yes.
Yeah.
We have to become better storytellers. I was interviewed from a young man here at University who is a videographer who's interested in storytelling and infrastructure, and so we have folks who are really focused at RTI now on narrative change, and there's a whole science behind it, right? And so we typically are not good storytellers, right? I think for me is thinking about narrative change, and I talked about this yesterday as a way of also addressing stigma. So how do we create new narratives around why this is important, and then how we demonstrate how things look different when we do it? I think there's enough evidence that we just, in the implementation space, that we've not written up. Challenge all of you to go back and look at your implementation data, how you've engaged community, and I'm pretty certain there's some incredible stories that haven't been told. We have to figure out how to do that. Now, part of that is, often descriptive work. Folks don't, you're doing a systematic review. Everything that's qualitative, it's kicked out, and we're only looking at the quantitative piece, and I think that makes sense. But what does a systematic review of quantitative findings look like? We don't do it. Because the journals won't accept it. We were missing so much learning if we could, so call it a scoping review, but you don't call it a systematic review. But I think the answer to the question already exists. We've already plugged the data. We've got to figure out ways in which to share it. And then thinking the last part of that is there's multiple and more than one way to disseminate what we do.
Yeah.
And so, yes, you got to keep doing your published journals. But I've also told folks, when you think about your dissemination plan, think about it day one, all these audiences. And its delivery is going to be very different. But think about it from the very beginning. This is what I need to do for the journal. This is what I need to do, the same information for the community and whoever the other important recipients of that data is. Think about it from the outset, so it doesn't become an afterthought or if I have time to get to it. Like, that's how we've got to flood the market, so to speak, to increase that awareness and then begin to have long-lasting change.
Yeah, that's fantastic. Thank you. I'm going to jump ahead a few minutes. So we're still in the Q&A period, but we'd love to have like a group photo at the end if we can. So stay
Whatever.
tuned. Yeah. Okay. Thank you.
Questions? Well, I don't see any immediate ones, so I invite everyone here to join us. Oh, sorry. Sarah, did you want to do it? Yeah, he wanted to do it. So sorry about that. So I wanted to invite everyone to join us over on the third floor BBH for a reception, food and drinks, and to continue the conversation. But before we end and before we take a group picture for anyone we can convince to join us, please. I did want to present Phil with the Bennett Lecturer Award. And so I'm not going to pick it up because I don't want to put fingerprints all over it. It's very pretty. But
I think we do have to take a photo, so.
Oh, okay.
So that's what I was told.
It's your award, so you can put whatever fingerprints you want on it. So, well, very well deserved. And I want to say thank you again for the amazing talk and the amazing 2.5 days we've gotten to spend with you. And now we can go and celebrate. Please, again, come join us, third floor BBH right over there for anyone who doesn't know. And we can continue the conversation. So thank you again.